Welcome, I'm Don Renfrew, and for the next hour or so I'm going to be talking about imaging of chest pain. I'm a member of the Radiology Associates of the Fox Valley, and I'm a private practice radiologist in Wisconsin. Radiology Associates is a 30-plus person radiology group covering 9 different hospitals in central Wisconsin. The hospital I work at most of the time is Door County Memorial Hospital, shown on this slide, and on this slide. Door County Memorial Hospital is a 25-bed Catholic hospital, and it has a relatively small radiology department as a 25-bed hospital would be expected to have. It is a critical access facility, and it's 50 miles from the nearest hospital. It's actually relatively geographically isolated in the Door County Peninsula. On the slide with the map, you can see where the star, the red star, is where the hospital is. It's about 50 miles or so from Green Bay. I'm usually the only radiologist in the hospital, and as such I answer a lot of questions from family practitioners and nurse practitioners and physician's assistants and other healthcare practitioners who want to know what study to order for a particular indication or symptom. I'm also director of grand rounds to Door County Memorial Hospital, and in that capacity I've built some lectures that discuss the topics of what study to order for a given clinical indication. This lecture is one of those lectures, and this lecture deals with imaging of chest pain. You have a lot of options for imaging chest pain, and you're not even really limited to what's here, the CT, plain films, nuclear medicine studies of the lungs, of the ventilation perfusion study, nuclear medicine study of the heart, myocardial perfusion study, plain films of the ribs, CT angiography now of the coronary arteries. There's a lot of different kinds of studies that you can do for patients with chest pain. And of course, at the same time, you want to order the right study the first time every time. And so my job today is to tell you what study to order for your patient with chest pain. The 4 points I'm going to make today are: number 1, there are multiple options when imaging chest pain. You have many different imaging studies that you can order to evaluate chest pain, and I'm going to review briefly what those are. Number 2, everyone with chest pain who needs imaging typically will get a chest x-ray. They may get other additional studies, or they may only need a chest x-ray, but pretty much everybody with chest pain who does get any imaging gets a chest x-ray. The third point is that in those patients that have severe shortness of breath, severe chest pain, and for those reasons or for any other reasons are suspected to have a pulmonary embolism, emergency chest CT angiography or CTA should be obtained. Finally, for those patients with suspected coronary artery disease, imaging depends on the clinical condition of the patient and risk assessment. And you're going to try to figure out 3 things with those patients. Is a cardiac event or infarction presently occurring? Is the patient's chest pain secondary to coronary artery narrowing? And how likely is the patient to have a cardiac event in the future? And your imaging will depend on which of those 3 issues you're trying to tackle. There are multiple imaging options. For chest pain, you can order any of several exams, like a plain film, CT scan, nuclear medicine, MR, ultrasound. Plain film examinations, there's a few different options here. Your standard 2-view chest x-ray. 2-view chest x-ray done in the department is typically done with the patient upright. It's done PA, so that the x-ray tube is behind the patient. The x-rays are coming through the patient from the posterior to anterior direction, or PA. And this creates the heart, it magnifies the heart shadow in such a fashion that it should be less than half of the transverse diameter of the chest. The lateral is also taken at 72 inches with the patient's left side against the film cassette or film recording device. It used to be that x-rays were x-rays in the sense that they were made on pieces of film and transported around physically. Now pretty much everything is done electronically, and the images are stored in packs and immediately transmittable to anywhere that has available, some login computer connection available with the packs. Single view chest x-ray, one direction only done if you're really worried about radiation. If it's a follow-up study, sometimes in other circumstances. A portable x-ray. Of course, portable x-rays are good for those patients who are direly ill in the emergency room or on the patient floor that can't be transported to the department. They're going to magnify the cardiomediastinal silhouette. They're not going to be as good of quality as an upright 2-view chest. Decubitus chest exam with the patient on one or the other side. Those were typically performed in the past to evaluate free-flowing fluid or small amounts of air and to see whether that would go to the dependent portion of the chest or not. Not very frequently performed anymore, frankly, because those have kind of been supplanted by chest CT exams. Rib detail exams, specific views to detect whether there are any broken ribs or rib lesions, a little higher detail. One note is that standard 2-view chest x-rays are technically optimized to evaluate lung parenchyma and the mediastinum, and because of that, they're shot with a higher KV, and that tends to burn out the ribs a bit, so you don't see the ribs all that well on a standard chest x-ray, and you'll see them much better on rib detail films. If it's important to know whether a patient's got a rib fracture, usually rib detail film is what you want to do, and in it you'll not only take the films with the lower KV, you'll also take multiple projections because the whole arc of the rib can be difficult to see on any one given projection. So here's an example of a standard PA and lateral chest x-ray. Nice young person. PA study, the heart size is less than half the transverse diameter of the thorax at that point. On the lateral, you see that the vertebral bodies become less white, more gray or black as you go from the top to the bottom. You see both claustrophrenic angles nicely. Actually, this film I clipped the photograph just a little bit, or the picture just a little bit, because the native chest x-ray did show those angles a little better. CT angiogram of the chest is another study that you can do. Typically, a standard contrast enhanced exam is obtained for cough and dyspnea. Now, for chest CT, you can optimize the enhancement of the arterial tree, and it's called a CTA, or chest computed tomographic angiogram. The data from the techniques post-processed to create specific views of the pulmonary arterial tree, usually in an oblique plane, and you optimize those for visualization of the main pulmonary arteries. For CT exam of the chest, you want to use contrast. That'll involve a power injector and typically non-ionic contrast. There are several varieties of contrast, as noted on this slide, and historically, the development has been sort of from the top of that slide to the bottom, with older generations ionic contrast supplanted by ionic and non-ionic contrast. I'll actually give a lecture about a third of which is devoted to contrast, so I'm not going to go into a lot of detail about contrast here. I will note that it's changed through the years, the agents at the bottom of the table had theoretical advantages. Isomolar contrast material and low osmolar contrast material tend to provoke less trouble on the part of the patient. They're probably no different in fatal anaphylactic reactions or anaphylactic-like reactions, but they are less likely to provoke more minor reactions like nausea and so forth. Coronary artery calcium scoring is another study done with a CT scan. It can be used to measure coronary artery calcium content, and so it's also called CACS, or coronary artery calcium scoring. For this study, you use an EKG but no contrast, and the idea here is the patient's hooked up to an EKG. A non-contrast study is obtained, and the data acquisition is coordinated with a heartbeat to eliminate motion, and then you measure how much calcium there is in the coronary arteries, and I'll kind of go into a little more detail on this particular study later. Another way of doing obtaining information, and this is a sort of an in-process or a new evaluation, is a coronary artery CT angiogram, or CCTA. In this study, you use an EKG to gate the information as you obtain it, and you also use IV contrast material. This is a map of the coronary arterial tree, and it's obtained with EKG and IV contrast. For a 64-slice scanner, your heart rate's got to be below 70, and many patients will require beta blockers to get to that rate. CT scanners with more slices and faster imaging can obtain CT angiography of the coronary arteries at higher heart rates, and we'll visit these visit this scan in the appropriate context. Rule out triple. What is a triple, and why are we ruling it out? Well, a triple is when you have somebody with chest pain that you're working up, particularly in the emergency room, that's severe in nature, and you're looking for pulmonary embolism, dissecting aortic aneurysm of the thoracic aorta, and coronary artery disease or heart attack. And at present, at least with our scanners as we're doing them now, a CTA or a CT of the pulmonary arteries and a CTA of the coronary arteries, it's hard to perform both of those simultaneously with the same bolus of contrast. Although as this technology evolves, we're probably not too far off from doing that. And as that happens, I think this is probably going to revolutionize the way emergency room medicine is practiced in terms of taking care of chest pain patients and imaging those patients. Nuclear medicine studies, there's a couple of different kinds of nuclear medicine studies that are performed in people with chest pain. Primary care providers may order ventilation perfusion lung scans for patients suspected to have pulmonary embolism and who can't have a CT angiogram because they've got contrast allergy or have renal insufficiency. Ventilation perfusion studies, they rely on the distribution of two different radioactively labeled substances. One's an aerosol that's used to evaluate ventilation, and then the other's an IV substance, which is filtered by the small level pulmonary vascular capillaries, and that evaluates perfusion. And you compare those two to figure out whether somebody has a ventilation perfusion mismatch suggestive of pulmonary embolism. Nuclear medicine studies also include infarct avid imaging, but those aren't done much anymore. That test has been largely supplanted by serial enzyme evaluations. And also myocardial perfusion studies. You can perform those at the time of a supposed cardiac event in equivocal cases, but that's not really the most common way that those studies are used. More typically, they're done with a stress test in patients who have clinical features suspicious for coronary artery syndrome. For myocardial perfusion studies, radioactively labeled material, usually tetraphosphate, labeled with technetium, but thallium in prior era, and also because technetium is intermittently available. It's a product that comes out of some nuclear reactors, and nuclear reactors becoming fewer and product availability becoming intermittent. We're going back to using thallium occasionally, although it's inferior from an imaging standpoint in a few different methods, in a few different ways. At any rate, whatever the tracer is, you inject that IV, and then you obtain images of the heart, and then either the same day or later in the same day or on a different day, you inject the material or scan the patient during load, and you cause load on the cardiac system by either exercise or drugs. And then you kind of compare those two, and what you're looking at is either fixed defects, which means there's an infarct that's occurred and completed and the myocardium scarred, or reversible defects that show up during exercise but reperfuse during stress, and those are areas that are at risk for infarction. So that's the cardiac perfusion study. And again, we'll look at an example of that later. Cardiac MR, well, despite years of intensive development and a lot of investigation, MR seems to be one of these things that's going to be development in the future rather than present. Right now it's used in research purposes and with ongoing developments it may find more use. It's usually used for people that can't have IV contrast in larger centers. The technique continues to evolve. It is possible that cardiac MR may one day provide a single modality that can look at the coronary arteries, cardiac valves, and myocardium in one exam. Right now, it's not really something that's going to be routinely ordered by primary care providers. Echocardiography, that's in use, of course, widely all over the place, but as a radiologist, I don't, at this point in my career, did once, but at this point in my career, don't interpret many echocardiograms or any echocardiograms, and that's because of the ongoing turf battles between cardiology and radiology. Cardiologists have tried to or successfully taken over the imaging of the heart in most places, including echocardiography. Echocardiography is good for evaluation of cardiac valves, looking at morphology, stenosis, and insufficiency. It's good for looking at the pericardium. It's good for looking at chamber size and wall motion. It obtains some information about heart and great vessel pressures. And it's the exam of choice for looking at acute valve insufficiency, such as somebody with heart pain or chest pain may have. And it's good for looking at patients with chest pain and a new murmur. These patients may have acute valve insufficiency, and that's critical to know. Since it's generally performed by cardiologists, I'm not going to speak a lot further about echocardiography. So, those are sort of your general tests available. So the next point is that everyone with chest pain who needs imaging basically gets an X-ray. Sometimes it's the only study you need. Now, how worthwhile is it getting the chest X-ray? Well, actually, frankly, a lot of times it doesn't really show you too much. Imaging of chest pain always starts with a plain film, but it doesn't often really reveal anything helpful or diagnostic. An investigator named Templeton found that about 23% of plain films obtained on patients with chest pain in the emergency room had an abnormality that influenced therapy. That's probably generous in my own experience, but he found 23%. The likelihood of finding a significant abnormality in a patient undergoing evaluation in an outpatient clinic is probably going to be even less than that, because those are ER patients. If you look at the table in this slide, you got 300 patients presenting to clinic. And this will show you why most of the plain films are going to be unremarkable, where you look at those causes of chest pain and they're not going to show much on a chest x-ray. However, I'm going to now review a few of your cases where you actually do see something on a chest x-ray as a cause of chest pain. And some of these patients came through the ER, probably most of them. There's a 52-year-old man with chest pain, and clearly here the arrows show he's got an acute onset of a pneumothorax. And of course, this is one of the things that pretty much everybody can recognize and should recognize as a cause of acute chest pain and dyspnea, shortness of breath. This fellow had it recognized pretty quickly and got a chest tube in this film, and this picture shows him before and after placement of the chest tube, and you can see his lung has reinflated nicely. Usually these pneumothoraces are secondary to a bleb or a little air balloon or pocket that's connected to the bronchial tree that's on the surface of the lung, rupturing, and then air collects in the negative pressure of the pleural space. They're typically self-healing. I mean, you don't have to go in there and put a stitch in them or anything. You put the chest tube in, the body heals it up. But during the time when that lung is down, people can be extremely uncomfortable and have a lot of chest pain because they're really kind of suffocating. Here's a 20-year-old man with chest pain, PA chest exam, very subtle abnormality on this exam, which I'll show you a blow-up of in a second. On the lateral study here, slide 49, with the same fellow, you see, again, a subtle abnormality. I'm not going to reveal what that is, but here's a blow-up of his cardiac shadow and of his anterior mediastinum on the lateral study. Everybody made up their mind as to what they think might be going on. The arrows point to small abnormal collections of air along the mediastinum here, and because of the suspicion of a pneumomediastinum, the patient was sent for CT. Now, a CT scan here, filmed with lung windows, shows a small amount of air right there along his aorta on slide 53. Slide 54, without arrows, and slide 55 here with arrows shows you air along the esophagus, and finally slide 56 and 57 with the arrows shows you air along the anterior aspect of the heart, causing the abnormality on his lateral chest x-ray, and some air there along his esophagus posteriorly. So this young man had a spontaneous pneumomediastinum. Pneumomediastinum can occur with or without a pneumothorax, and generally it's a cause of chest pain that can be diagnosed on the chest x-ray like pneumothorax, it's more easily seen on a CT scan. Here's an 86-year-old with some persistent chest pain following trauma. His chest x-ray didn't look too bad. There's his frontal study. Here's an oblique view of the ribs. Hard to see much going on there. Blow-up oblique view of the ribs. You're on slide 62, slide 63. If you look real hard, here's the arrows that show you that rib fracture. And then here's a two-view, one of his chest x-ray and one of the rib fracture. Now, rib fractures, how important are they to diagnose? It is good to have a diagnosis in many cases, especially if you're dealing with someone with chest pain. But rib fractures can be all but impossible to see on the chest x-ray because of the technique they're taken with. However, you'll see the significant complications of the rib fracture, such as the hemothorax and the pneumothorax, which are actually more important to know about than the rib fracture per se, typically, clinically. If someone is point tender along a rib and has had trauma to that rib, the rib's probably fractured. Whether we can see that or document it on an x-ray or not is probably neither here nor there. The important thing is, do they have a pneumothorax? Do they need a chest tube? The other issue is that frequently ribs will fracture at the costochondral junction, and those will just flat be invisible pretty much on a CT, even a CT or x-ray or whatever you want to do to try to find those things. So basically, rib fracture is more important to know that they've got a pneumothorax or hemothorax than it is that they have a rib fracture. But it is, it's always good to make a diagnosis. Okay, 70-year-old woman with chest pain, a chest x-ray. You'll note that on this frontal chest x-ray, her breast shadows are asymmetric. She did not have a mastectomy, but she does come in with chest pain. Her lateral study looks a little fishy, if you know what you're looking for, what you're looking at. And on the frontal and lateral study, I think the thing that you can best appreciate is the fact that her bone texture is abnormal. The thoracic vertebral bodies are not really the right color. They're mottled and too dense. Her ribs, you could probably say the same thing about. Here's a chest CT that was obtained, and you'll notice how distorted the tissue is on her left side along the pectoralis muscle there. Again, she did not have a mastectomy. Here on image 71, we see a great deal of abnormal texture in her vertebra. There are areas of basically sclerosis here with this arrow, another arrow, for two arrows showing additional sclerosis, more sclerosis back here. I mean, everywhere you point to in this vertebra, there's abnormal texture. And there's some areas of lucency. It's hard to tell whether that's normal bone or whether that's abnormally moth-eaten bone from tumor. Here on slide 77, you see a coronal reconstruction of her CT data, and you can figure out in a hurry why all acquired lateral and chest x-ray looks so abnormal. Here are arrows along all the abnormalities in her thoracic spine. On a sagittal reconstruction, sort of mimicking the lateral chest x-ray, you see a bunch of sclerotic lesions in the sternum and throughout the spine. Just a set of arrows, which I got a little carried away with. Here's a composite of all four pictures. The chest x-ray showing the retracted breast shadow from a large primary breast cancer. The two-view chest and reconstruction CT showing diffuse metastatic blastic bony deposit in this patient with chest pain and diffuse metastatic deposit. So the chest x-ray did show the cause of the chest pain in this patient. And occasionally you'll have patients that come with metastatic disease as the cause of their pain, and you'll see that on the chest x-ray. Here's a 47-year-old male with chest pain that came in, and he obviously has a large lesion there in the left chest. On the lateral study, and the lateral study with arrows, you see that large round area of opacity in the posterior chest. He did get a CT scan. Here you can see a combination of consolidation and ground glass opacity. Radiologists use the word consolidation, meaning on a CT scan, lung density that obscures the lung markings and vessels. And then they use the term ground glass opacity for increased density that is greater than normal lung tissue but less than consolidation, and which in general does not obscure the native lung markings. Here are two arrows showing that area of combined consolidation and atelectasis. And here's the same fellow with the chest CT on slide 89, filmed at soft tissue rather than chest windows, and you can see that the ground glass opacity sort of goes away. The effusion fluid along the oblique fissure and posteriorly stands out more on this picture. The arrow here is on a mildly enlarged hilar lymph node, not infrequently seen in those patients with this condition. Here's a sagittal reconstruction of the chest CT showing you what you're seeing on the chest X-ray, large area of consolidation, ground glass opacity, here marked by the arrows. And finally, here are 4 different pictures showing the chest X-ray, PA and lateral view, axial CT, sagittal CT, sort of correlating those findings. So this is pneumonia causing chest pain in a 47-year-old man. This is a so-called round pneumonia, which can mimic a mass. A follow-up chest X-ray after treatment demonstrated complete clearing of this pneumonia. So these are some of the other causes of chest pain. You might also see things like painful arteriovenous malformations, painful pneumonia, aortic dissection, esophageal rupture. Sometimes the diseases have abnormalities on chest X-rays that aren't specific and you need a CT. Sometimes even the CT doesn't help you entirely. For example, here's a 75-year-old man with chest pain, abnormal chest X-ray. Here's a chest X-ray of him done earlier that was pretty clear. Months before the one that he came in for his chest pain for. So here's a 2-view, A and B. A, previously when he was less symptomatic, there was a portable study, so you can see it kind of magnifies the cardiac mediastinal silhouette, the mediastinum in the heart compared to the other view. Here's an axial CT done when he was symptomatic with chest pain, showing again scattered areas of ground glass opacity, here noted by the 5 arrows. A coronal reconstruction, same gentleman, shows multiple areas of abnormal opacity in both lungs. Here's a composite picture of the 2 chest X-rays before and after his acute onset of chest pain, and the chest X-ray showing multiple areas of opacity. And it wasn't really clear what was happening to this guy, because it's not representing one of the usual things that we just showed. It's not a tumor, it's not a pulmonary embolism, which I'll talk about in a little bit. It's not pneumothorax, there's no rib fracture, there's no mets here, what's going on? Well, when the additional picture, the additional clinical information became clear that this man was on anticoagulants and had a sudden drop in hematocrit and was coughing up blood, then it became much more clear that this was all representing a pulmonary hemorrhage. I think it would be difficult to make that diagnosis just on the imaging findings, but when you put all that clinical information with it, it does help a great deal. Again, this is a very unusual cause of chest pain. So again, this is the table showing you why most of the time you're not going to see a lot of stuff going on with a chest X-ray in patients that come in with chest pain. Okay, so that brings us to the next topic. For patients with suspected pulmonary embolism, emergent chest CT should be obtained. Now, here are clinical decision rules that are used in patients with acute onset chest pain to try to evaluate whether they need to be considered at high risk for pulmonary embolism. Pulmonary emboli frequently cause chest pain. They remain a common cause of mortality, but emboli can frequently go undiagnosed. And this follows from the fact that the classic patient presents with acute onset of severe chest pain and dyspnea, but many patients have a more subtle presentation. One approach calls for scoring on the basis of what are known as the Wells criteria, as seen in this table, and then you perform a chest CT angiogram if the likelihood of pulmonary embolism is high, but you get a D-dimer if the likelihood is low, and in that case, if the D-dimer is elevated, you go ahead and get the CTA. So, plain films are really neither sensitive nor specific. Here's a chest X-ray on a patient with a pulmonary embolism that shows nothing. All these patients typically will get a chest X-ray because all patients with chest pain typically get a chest X-ray. It's always obtained pretty much, but it's frequently, it is actually fairly frequently abnormal, but it's not often very helpful. And the reason for that is that at least one investigator found 84% of chest X-rays in patients with pulmonary embolism showed something wrong, but patients without pulmonary embolism had similar abnormalities at about the same rate. So 69% of patients with pulmonary embolism had a parenchymal opacity, but 58% of those without a PE had that. 47% of patients with PE had a pleural effusion, but 39% without had a pleural effusion. So there's a wide variety of diseases, and many of which cause chest pain, which may result in these non-specific abnormalities, like pulmonary opacity and pleural effusion. So the chest X-ray at the end of the day usually isn't all that helpful. So CT angiography is now the study of choice. Pulmonary angiography performed with an intravenous catheter through the groin into the femoral vein and brought into the usually into the cava, right atrium, right ventricle, contrast injected, even the pulmonary outflow tract, contrast injected, and then pictures of the pulmonary arterial tree. That was once the mainstay of diagnosis, and it probably is still considered the reference standard, but it's basically been replaced by CT for several reasons, mostly because CT is far more widely available, faster, cheaper, and less prone to causing trouble with the injection site and so forth. CT does allow quantification of emboli size. It demonstrates emboli location and a diagnosis of any associated pulmonary infarction pretty well. It also allows how severe the disease is, because what kills people with pulmonary embolism is right heart failure, and CT will show you whether the right heart is increased in size. If it's bigger than the left heart, that's too big. If the interventricular septum is bowed, that's not a good thing. So it will also show you these findings of severe disease with a bad prognosis. Pulmonary arterial distension to greater than 30 millimeters is also a bad prognostic sign. The other thing about pulmonary CT and CT angiography done for pulmonary embolism is, as I mentioned in another lecture, when patients come in with acute stone disease and get a CT, acute kidney stone disease or acute flank pain, felt to be secondary to kidney stone disease. There's a lot of times where the CT will show you something other than kidney stone disease. Same deal here. When somebody comes in with acute shortness of breath and you're thinking pulmonary embolism, they will have other diseases diagnosed on the CT, and the CT is good for diagnosing those other diseases, so that's usually a good thing. Now this 28-year-old with chest pain I'm showing not because she has a pulmonary embolism, but because there's some pretty nice normal anatomy here. Here's the main pulmonary artery with the arrow. Here on image slide 116, the bifurcation on the left and right main pulmonary, the left and right pulmonary arteries. Here's one of those oblique reconstructions that I talked about earlier. The arrow is on the pulmonary artery and its branches, and you can see how beautifully CT with an intravenous injection and reconstructions can show you the pulmonary arterial tree. Here's the contralateral pulmonary arterial tree. Again, an arrow on the pulmonary artery on that side. And a composite picture showing you beautiful pulmonary arterial tree in this 28-year-old woman with a normal study. Here's a 74-year-old woman with dyspnea and a pretty normal-looking chest X-ray. Here's a CAT scan through her chest done with a CT angiogram technique. And on this image, the pulmonary artery is labeled, as is the aorta, and you can see several filling defects in the right pulmonary artery, and then also in the left, or a branch of the left pulmonary artery there as well. The patient has multiple pulmonary emboli, and usually pulmonary emboli are multiple. Such filling defects are basically classic for acute pulmonary embolism. This 61-year-old had acute dyspnea after some recent abdominal surgery. This image has arrows on both left and right pulmonary emboli, big nasty emboli. The prior CT scan on the left shows, and again the timing of that bolus was different, and that study was not performed for pulmonary embolism, but the image on the left versus the image on the right, you can see where the arrow is. The pulmonary artery has gotten considerably larger when this fellow has his embolism. Now this picture shows you on the left that the right ventricle several months before has normal size, whereas on the right, with the pulmonary emboli, the man has a dilated right ventricle. That's a poor prognostic sign, as I noted before. Now, so CT angiography is your main study when you're looking for pulmonary emboli, but for those with a history of hypersensitivity reaction to IV contrast or renal failure, then you can use the ventilation perfusion lung study. This was long a mainstay of diagnosis, but it's sort of been supplanted by the CT angiogram now. If you see multiple mismatches with ventilation going to areas of the lungs where there's no perfusion, then that's diagnostic of pulmonary embolism, basically. If you see a perfectly normal perfusion study, that essentially excludes pulmonary embolism. A lot of studies are indeterminate, however, and kind of fall between those two. So this was a patient with renal failure that had a normal perfusion study excluding pulmonary embolism as a cause of her chest pain. This 80-year-old man had acute onset of shortness of breath, and he had chronic renal failure. The perfusion study shows a hole there in his right upper lobe that was not present on the ventilation study, marked B. Here, C and D show you, again, perfusion abnormalities in an area that's relatively normally ventilated. This man had multiple perfusion, mismatched ventilation perfusion defects. So he had pulmonary emboli. Now, lower extremity ultrasound, another alternative to CT, if you have renal failure, contrast allergy, or whatever, is to go ahead and perform a lower extremity venous ultrasound study. Why? Well, most of the time the clot that are in the pulmonary arteries has come from lower extremity veins. And most of the time, if somebody has pulmonary emboli, not all of the clot from the veins has become dislodged and gone to the pulmonary arteries. So, if you scan the legs and see deep venous thrombus in the lower extremities, it pretty much provides you with strong evidence that the patient has a pulmonary embolism if he has acute onset of shortness of breath, and the treatment is going to be anticoagulation anyway in those cases because those patients obviously have DVT and need treatment. So that brings us to the end of the discussion about pulmonary arterial emboli, and that takes us to the last category of disease today, and that's coronary artery disease. Imaging of coronary artery disease depends on the clinical condition of the patient and risk assessment. So with coronary artery syndrome, you kind of got three different critical issues. One is the patient currently having a cardiac event as the cause of their chest pain. Right now, are they having coronary artery ischemia or a heart attack, whether they have dead or dying myocardium? Point number two, does the patient's chest pain in general, if he has got intermittent chest pain, is it coming from a coronary artery narrowings? Is he having angina because of coronary artery narrowings? And then point number three is, how likely is it that this given patient right here is going to have a cardiac event sometime in the future? You know, what's the likelihood of that happening? So those are sort of your three different things you need to think about. Now, in those patients who obviously have a coronary, are obviously having a heart attack right now, have severe crushing chest pain, diaphoresis, short of breath, thickening, well, you know, you name it. Those patients that obviously are undergoing a heart attack should go right to the emergency room. In the meantime, the best thing that you can probably do with them if they show up in your clinic with that scenario, or somebody, you get called out into the clinic or you see somebody with that, is if you've got it, start an IV and draw blood for enzymes and get an IV running and have them chew an aspirin. And then arrange for transport to the ER or the cath lab. And if you're arranging transport to the ER, make sure there's a defibrillator and whatever you're transporting them there, and if you've got that opportunity. You can wait, everybody with chest pain gets a chest x-ray, well, sure, but in this case, there are other more important things to do first, like get them to the cath lab or the ER. They will get their chest x-ray sooner or later, but the clock's running. You got about 60 or 90 minutes to save ischemic myocardium that's undergoing infarction, so you got to move on it. What's happening usually with these patients is they've got coronary artery plaque that's probably been building for years, but then they've now ruptured that plaque or bled into it, or a piece has come off and it's lodged. Most of the time it's just ruptured into the plaque, and the plaque, which was along the wall of the coronary artery before, is now plugging it up. These patients need to get up to the cath lab and have that diagnosed via coronary arterial examination with a catheter in the artery, once they had that the diagnosis of narrowing or obstruction made, they can either get a stent put in if they're a candidate for that, if that's going to work for them, or have a cardiac bypass surgery if that's what they need. That's basically all. Those are basically all decisions that are not really made by primary care providers or general practice radiologists like me, but I'm just telling you that because that's kind of what's going to happen downstream, of course, to your cardiac patients. And there's everybody taking care of cardiac patients. There's so many of them. Here's a 92-year-old man with chest pain. Here's a chest X-ray that shows florid congestive heart failure with cardiomegaly and bilateral pleural effusions and flooded central pulmonary vessels and so forth. Here's a prior comparison study on this man who had a heart attack and was in florid congestive heart failure. The patient had abnormality on EKG and abnormal cardiac enzymes, and didn't make it too long after that chest X-ray was made, actually. So acute event, off to the cardiac cath lab. How about those patients that have chest pain, but it's hard to tell whether they have cardiac chest pain or not? The drama of the patient presenting with an acute myocardial infarction is really the exception and not the rule for a patient seeing a primary care provider for the evaluation of chest pain. Most of the patients come in because of angina, of stenosis, although sometimes their symptoms are often, atypical. To decide which study to order on your patient when they have chest pain and you're thinking in terms of coronary artery stenosis, you have to sort of put the patient in a risk category, such as is accomplished by this table here. You got to calculate the pretest probability of coronary artery disease by assessing their chest pain pattern and correlating the pain pattern to their age and sex, and then you put them in one of these categories. And then what do? Well, low-risk patients with a pretest probability of less than 5%, young patients with atypical pain, they're unlikely to benefit by any test, and usually your test is going to be stress EKG or perfusion imaging study. Why? Because if you have a positive test in those patients, it's much more likely to represent a false positive test than to really represent true disease. High-risk patients, in other words, the ones that are greater than 90% likely to have disease, you don't really want to test those either because the likelihood of a false negative test is higher than a correct test. So you really need to ship all those 90+% possibility patients off to a cardiologist and have them evaluated. They'll probably need cardiac catheterization, really, although they make it non-invasive studies done, but typically, if you're at that high of risk, you'll probably need to have catheterization done. Now that leaves you a lot of tests, intermediate people between, and this is kind of a squirrely thing about this table, intermediate risk is considered between 25 and 75%. Now, that leaves a lot of people out there between 5 and 25 on the low end and 75 and 90, and it's really unclear as to what to do with those. But the ones between 25 and 75%, those you go on to EKG stress EKG test, or a stress EKG plus myocardial perfusion, or stress echo, one of those kind of studies. Now, I'm going to talk here about the cardiac studies. The imaging component of these exams is usually added. Well, some people just routinely add it every time they do a stress EKG. Other people add it when this baseline EKG has abnormalities, making interpretation of the stress-induced changes problematic, or when the patient's on digitalis, or when there's been previous revascularization, or when your stress EKG done without imaging was equivocal. Now, the addition of the imaging improves sensitivity in the intermediate risk patients by about 20%. And for that reason, a lot of people just routinely order the imaging when they do the stress EKG on those intermediate risk patients. So again, to back up just a second, we're talking about outpatient evaluation of somebody not in acute chest pain but having intermittent chest pain, and you're thinking this guy is coronary artery disease basically the cause of this patient's pain. Here's a 64-year-old man with exertional chest pain. Here's a myocardial perfusion study, and it's a little hard to follow because there's so many pictures there. But to kind of boil it down, the arrow is on the big hole in his myocardium during the stress study, and the resting study shows reperfusion in that area. Obviously, this guy's got a big reperfusible defect in his heart, and the computer-generated map shows you all those numbers over there show you that he's got reversible ischemic changes. He underwent cardiac cath. He had diagnosis and stenting of the left descending coronary artery stenosis. He had relief of the symptoms. Now, you usually use the SPECT images by comparing the rest and stress images, and the reversible areas are the ones that probably are going to benefit from, coronary artery catheterization, diagnosis, and stenting. Here's an 81-year-old man with, frankly, pretty typical chest pain, and his pretest probability of cardiac disease was up in the 90s based on information available at the time of the perfusion study. His perfusion study was normal, but he went on to coronary arteriography because his risk was so high, and he had severe LAD narrowing despite the fact that he had a negative perfusion study. Perfusion studies can be false negative, and if you have a high enough risk patient in the 70s or 80s, or particularly in the 90s, you want to send those to cardiologists and not waste the patient's time and money basically with the perfusion study, because it's just not going to be useful in those situations. What can be useful in those situations? Well, in some situations, coronary artery calcium scoring and coronary CTA are useful. They're undergoing rapid evolution. Inclusion of these tests in the algorithm for the workup of suspected coronary artery syndrome depends on the equipment you have locally, the expertise you have locally, and the physician acceptance there is locally. For patients with non-anginal chest pain or squirrely chest pain that's unlikely to represent coronary artery stenosis, that calcium scoring test offers an alternative to the stress test, or an additional test which can be helpful when the stress test is negative or equivocal. For the coronary artery calcium scoring to be helpful in this scenario, and we use it in another scenario I'll talk about in a second, but to be useful in this scenario, the score has to be 0. One researcher found that if the score is 0 for the coronary artery calcium scoring, the annual cardiac event rate was less than 1% per year over the next 5 years. Another investigator found only one cardiac event among 48 chest pain patients with patients that had a calcium score of 0. That one event was in a cocaine user, and when you have cocaine users, sympathomimetic drug abusers, you kind of throw out these rules because they can go into vascular spasm and rupture aneurysms and all kinds of other stuff. So at any rate, you got to throw that guy out. But apart from that, if the calcium arteries, the coronary artery calcium score was 0, 30-day event rate was 0. In those where the calcium artery scoring was greater than 0, in this particular investigation, 8% of those had an event in the next 30 days. So these researchers concluded that calcium artery scoring was a good thing in the acute situation to exclude coronary arteries as a cause of the disease. How about CCTA, or coronary artery, and again, coronary computed tomographic angiography? Again, this is performed with EKG and IV contrast, and this is really undergoing a rapid evolution. If the calcium score is not 0, if you want to look at the coronary arteries but you don't want to go to the cath lab, this is your study. But the ordering and interpreting control of this modality is very controversial, mainly because of the turf war it provokes between cardiologists who have usually done all the cardiac imaging, echoes, cardiac caths, myocardial perfusion studies, and the radiologists who usually read everything that comes off the CT scanner. So when you've got this particular study, it's provoked this turf war. From the perspective of the ordering primary care provider, what really matters to you and your patient is that the test done correctly and interpreted accurately. At present, the ability to perform this test isn't widespread, but it will get there in a hurry. If it is available to you, which of your patients do you want to send for it? Well, present recommendations, and these are evolving pretty rapidly, but present recommendations call for patients of intermediate risk, including those with an equivocal stress test, patients with known or suspected congenital or acquired coronary artery anomalies. In other words, these patients are going to be kind of hard to cath, and patients with bypass grafts where you can't engage the graft during angiography. So right now, there's not, the current hard recommendations for CCTA are not vast, but they are evolving, and I think that this is probably going to be a huge thing in emergency rooms in the coming years. And here's why. Here's a picture. I mean, look at that picture. The picture's worth 1,000 words. 52-year-old man with chest pain, and this is the kind of imaging you can get with CCTA. The composite figure shows you a reconstructed view of the heart and coronary vessels obtained with EKG gating. The LAD is depicted along the surface of the left ventricle. The long arrow is connected with the associated cross-sectional imaging, and images proximal to the level of the arrow are arrayed above the target location and the more distal locations below it. Along the right side, there's two longitudinal reconstructions of right angles of the LAD. Now note that on that right-sided image where the arrows are, there's a significant or greater than 50% stenosis of the proximal coronary artery where the double arrow is. I'd like to thank Mark Millen, my associate, Radiology Associates, for providing me with this image. It shows you what the future probably of coronary artery evaluation is going to be. Okay, so what about screening? What about the risk of future events? I mean, we've talked about, is the patient having an infarct right now? We've talked about, is there chest pain coming from the coronary artery stenosis? And now we're going to talk about, what about the risk of future events? There are two separate risks, and this can get confusing in a hurry, but there are two separate risks when cardiologists and others talk about coronary artery disease. One is the risk that the patient that has chest pain has significant coronary artery stenosis. That's what I've just been talking about. The other risk is that the patient's going to have a cardiac event, typically defined as either death, infarction, or surgical or percutaneous intervention in some specified time period. So that's what's going on in the future. In the two prior sections, I've discussed the patients who are having a cardiac event right now. Their risk is 100% because they're having an event. And then there's the patients with coronary artery stenosis, where you're trying to figure out, does this patient with, what's the likelihood of this patient with chest pain having coronary artery disease? Patients with coronary artery stenosis have a high risk of future events, as do ones that have already had an event. Generally, these people are already seeing a cardiologist. Now, in these patients, there's either plaque, which is ruptured, or there's been a demonstration of plaque, which is going to rupture or cause trouble, or could. Absent current infarction right now or a known stenosis, in a patient even without any chest pain, what's the risk of a future event? Now, you can calculate that on the basis of age, sex, total cholesterol, HDL cholesterol, smoking status, systolic blood pressure, and whether or not the patient's on antihypertensives, along with serum cholesterol. It's a lot of variables, but basically those are all pretty readily obtainable. And generally, risk is spoken of in 10-year increments. So low risk, it means less than 10% chance of a cardiac event in the next 10 years. Intermediate risk between 10 and 20%. High risk greater than 20%. And the online calculator will show you those risks. And you can go to any one of the number of websites will have those calculators for you. Note that you don't bother with the calculator. Anybody that's had a cardiac event already or has diabetes is at high risk, kind of automatically. So you don't have to plug in all the numbers if you've got diabetes or you've already had an MI. You're at high risk. Now, when are you going to use? What methods do you use to screen patients for future events other than that calculator? At present, there is an imaging method, coronary artery calcium scoring. This method, again, is the same technique where you use an EKG, no IB contrast, and you calculate the amount of calcium in coronary arteries. More calcium in coronary arteries means higher rupture, higher likelihood of significant plaque, higher likelihood of rupture, higher likelihood of cardiac event, either an MI or death. And the calcium scoring actually predicts quite well all-cause mortality, better than the other method of serum cholesterol and an equation. This is a picture of coronary artery calcium scoring, and basically the little line there is around the left coronary artery, and it's trying to capture all the calcium. The slide here on 191 shows you a 62-year-old with known coronary artery disease. This is a blow-up of the same image, and you can see that this guy's coronary artery calcium score was between the 25th and 50th percentile. And the meaning of that is over here on the right side of this readout, where it tells you how likely it is that that guy has significant narrowings and so forth. It's interesting that coronary artery calcium scoring, a lot of places will perform coronary artery calcium scoring on a self-referral basis. At the same time, CMS and a lot of the insurance companies don't cover it. But there's been a lot of marketing of it, and many people elect to have it and pay for it out of pocket. So what will happen is that patients will come to the primary care provider having already obtained a coronary artery calcium score. What do you do with that information? Well, basically the American Heart Association says we'll only get a coronary artery calcium score if your risk is intermediate on the basis of your standard calculation by your serum cholesterol, blood pressure, and so forth. Now, if somebody comes to you as a primary care provider with a coronary artery calcium score, then you gotta go ahead and calculate their score by the typical method of that calculator. And then if they're at an intermediate risk, they should have gotten a coronary artery calcium score, the CT study anyway. In that case, if they have an intermediate risk and they have an Agatston score of 0, then you really don't change their management. If they have a high Agatston score, then you probably upgrade their category and treat them more aggressively to lower their serum lipids. It's more confusing when they have a high risk by their other determinants, but a low risk or a 0 score by Agatston. It's probably somewhat reassuring. As far as using the Agatston score or the pictures to motivate somebody, there's one investigator that found that visual presentation of that data or even knowledge of what that score was didn't really motivate people or change their compliance or improve their compliance with their medications. So that's kind of in a nutshell what's going on with coronary artery disease. And again, just kind of recapitulate briefly, somebody having an acute coronary event right now, having chew an aspirin, call the EKG, get the IV started, get them to an ER, get them to cath lab right away. Somebody who you think may be having coronary artery narrowing and intermittent anginal chest pain on the basis of that. Look at that table, figure out what their pattern of pain is. If they're a really low risk, you probably don't want to image those patients because you'll likely get a false positive. If they're really high risk, they need to go off and talk to their cardiologist and probably get a cath. If they're in the middle, stress EKG, often done with myocardial perfusion imaging. And finally, to try to figure out risk on patients, the risk calculators that are available online that take into account the usual features, possibly supplemented by coronary artery calcium scoring. CCTA, rapidly evolving, and will probably come to your town if it hasn't already pretty soon, and you're going to have to figure out how to incorporate that into this other information. So, in summary, I've reviewed imaging chest pain. I talked about all the options that are available for imaging with chest pain. I talked about the fact that pretty much everybody gets a chest x-ray, although it's not often all that helpful, but everybody gets one. I've talked about pulmonary emboli and how it's important to get a CT angiogram as quickly as possible in those patients that have a suspected pulmonary embolism. And then I talked about coronary artery disease and coronary artery syndrome. Thank you very much for your time.